Very good afternoon, Honorable Chairperson Professor Bashir Ahmed. We have got two learned teachers, Professor Shirazul Haq sir and Professor Yaqub sir, our Secretary General of Azan Association, Professor Shahid Rahman Khan. My colleagues, I am not mentioning all the names, all the expert panelists present in this session and the learned audience. It's really very interesting and very encouraging to be present in today's seminar. And the presenter, Dr. Muhammad Tawhid Zaman, he is my student. I feel very much proud of him because of his presentation. This is really a brilliant presentation because pulmonary hypertension is a large topic, and to encompass all the aspects by a single speaker is not scientifically sound also, and it's not feasible also. But he tried to precisely mention every aspect. So I will be just have an overview over his presentation. And I have to mention here today, this pulmonary hypertension is really less talked, less discussed, less diagnosed, at least in the third world countries, especially the Asian countries. The data registry is also very scarce. So we don't have exactly the prevalence of pulmonary hypertension in our country or even in our neighboring country. So we have to depend on the Western data, which tells that approximately 1% of global population suffers from pulmonary hypertension. But the vast majority of this pulmonary hypertension includes cardiovascular cause and respiratory causes. But whenever we discuss pulmonary hypertension, practically our attention is towards pulmonary arterial hypertension, rather group 1 pulmonary hypertension. Now, if we consider those aspects, the thing already has been discussed. The main important aspect of this is to suspect pulmonary hypertension in a patient, especially the younger patient who have got undue tiredness. Well, somebody might have along with that palpitation, cough, hemoptysis, even chest tightness. All sorts of problems might be complained. But undue tiredness by a young adult must always, the clinician must always look for what my sir has mentioned, a loud P2. So the thing is that we can measure blood pressure, but we cannot directly measure pulmonary arterial pressure. But we can definitely listen to the loud P2. And whenever you suspect there is loud P2 or there is evidence of any pulmonary right heart hypertrophy, right ventricular parasternal hip, you have to do an echocardiography. Though the echocardiography is not diagnostic because the cutoff value previously that was 25 millimeter, now it has become 20 millimeter, and the probability of echocardiography, there is a variability, low to high. So whenever there is low probability, then many times we may be confused, and in some cases we may need to do cardiac catheterization. So this again requires the cooperation of interdisciplinary personalities, doctors, especially the cardiologists and the pulmonologists. Again, this pulmonary arterial hypertension, 23% of pulmonary arterial hypertension patients are belonging to connective tissue diseases. and among them, 62% belongs to systemic sclerosis and 38% non-systemic sclerosis. So again, the important role must have to be played by the rheumatologist. So the laggings in our country, sometimes we say why our patients are going abroad for treatment. Well, always this is not true. There are reasons. Because we cannot show you one center under the same umbrella where you can get all the facilities to diagnose, treat, and follow up a patient of pulmonary hypertension. Maybe this is true for some other diseases also, especially oncology. But we are concerned now with pulmonary hypertension. So the problem is that our settings are not well equipped. Regarding persons, regarding logistics, regarding fundings also. So the great barrier here is the lack of awareness regarding the need of such a center to deal with pulmonary hypertension. In Western countries, you go, there are centers for pulmonary hypertension, where there is a collaboration between multidisciplinary physicians. So we will have to think of this. If we suspect a patient of pulmonary hypertension, ultimately we can diagnose with echocardiography. Thereafter, you do the pulmonary function test, you do CT scan to exclude the lung pathologies. You can have even cardiac MRI, echo, and other cardiac investigations. And if needed, I can assure that you can have a team with cardiologists to do a right heart catheterization. And a vasoreactivity test is required, not in all cases, only in idiopathic, heritable, and drug related pulmonary arterial hypertension. So, this, and regarding the treatment, he has nicely mentioned most of the drugs are IV, but the first two groups of drugs, I mean the endothelin group and the nitric oxide group, there are oral drugs available, but prostacyclin groups are mostly, except the selexipag, these are IV. So, and also he has mentioned rightly that the initial treatment should be initial combination therapy. And one question was asked here, the pulmonary hypertension with idiopathic or connective tissue diseases. Well, if there is DPLD, you will have to treat the underlying cause, but the treatment algorithm of pulmonary hypertension of idiopathic and connective tissue disease will be the same. And regarding prognosis, already has been mentioned. Well, previously it was mentioned that pulmonary hypertension is a gone case, there is no hope. But nowadays this is a treatable condition. The term is now mentioned that this is treatable condition. And I want to conclude saying one of my patients, pulmonary hypertension, which I dealt in my private hospital, because not all the patients will be able to afford all sorts of advice we give those patients. She was capable of doing all the things, and ultimately we referred her for lung transplantation to India. And she successfully completed her lung transplantation. The treatment was very much successful and hopeful. Well, unfortunately, she died of other problem thereafter. That's a very sorry story. Even then, we are optimistic that those who can afford, there is hope even to survive with lung transplantation. Thank you very much for patient sharing. Thank you.